This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So I'm going to talk to you today about influenza. I know I'm the second in the series, so I'm going to start with the basics, and we're going to go through a little bit of lab, some clinical, vaccine and antivirals, and then we're going to go into the public health realm, which is where I approach influenza from, and talk about what's going now as far as all the different avian and swine flu issues out there. So we're just going to have a snapshot of what's happening with influenza. So I'm going to start with really basic stuff. Actually, Dick Jacobs next week has a similar slide. I just thought I would borrow it and elaborate a little because I'm before him. So influenza is a virus. And the two big categories, there are others, fungi and parasites, are bacteria that are big and viruses that are small. Bacteria can replicate independently, and they have all the machinery needed to do so. So they have ribosomes and proteins, a lipid bilayer. They can exist anywhere: water, ocean, snow, plants, animals, humans, our intestines. They are often beneficial and sometimes harmful, and they respond to antibiotic therapy. So in contrast, viruses are very small. So you can see on this electron micrograph here, this is probably around, this is also an EM. You can see bacteria at 100-fold in a microscope. But this is 100,000, and you can only see viruses by EM or electron micrograph, so they're very, very tiny. They consist of fairly simple components, a protein coat with either RNA or DNA inside. And the main difference between bacteria and viruses, besides the size, is that they need to infect a mammalian cell or a plant cell, another cell, in order to survive and reproduce. So they take over that host cell's machinery in order to replicate, and then they release little virions from that host cell, and that's how they reproduce. They cannot reproduce without using another host cell as their host. For that reason, they usually cause disease because they are invading other host cells, and they don't respond well to antibiotic therapy. So influenza is a virus, and this is the influenza virus, and it's made up of a membrane. And then there are these surface proteins, and I think many people now know that the main ones are hemagglutinin, that's one surface protein, and neuraminidase. These are the main ones. There are others, but these are the ones that we think are important as far as when your body sees an infection, it generates immunity, and vaccine is targeting this particular hemagglutinin protein. There's also inside 8 RNA segments, and these are physically discrete segments, and this is important. Because when an influenza virus infects a host cell, and there's another virus in the same cell, those segments can mix and reassort and create a new virus in 256 possible recombinations. So that's how the influenza virus maintains its genetic diversity in nature. This is the typical way that we name a virus, so there are different strains. There's 3 types, A, B, and C, and A and B are the ones that cause disease in humans as far as we know. When you name a virus, an influenza virus, you usually use the laboratory where it was first isolated, a lab number, the year you found it, and the hemagglutinin neuraminidase subtype. So for example, this A. California H3N2 virus was actually identified in California in 2004 at our state lab and became the predominant circulating virus worldwide and was then incorporated into the 2005-06 vaccine. So that's the importance of why we name these viruses. Okay, so there are 16 hemagglutinin subtypes. There's 16 different antigenically distinct proteins sitting on the surface, one of them. And the reason this slide's important is because it shows some of the reservoirs in animals for the influenza viruses and these different hemagglutinin subtypes. So humans, obviously, but also pigs, horses, and the primary reservoir is birds. And a lot of this happens in wild birds, and they may not be symptomatic. And the point of the slide is that influenza will never be eradicated, unlike polio, unlike measles, because we have a huge animal reservoir where the virus can hide and live and replicate and evolve, and then pass it back on to humans. So likewise, the neuraminidase protein, there are 9 different types. And again, wild birds are the major reservoir where all 9 different subtypes of neuraminidase can circulate and survive. So influenza is unique because these surface proteins can change. And so we have 2 types of change. We have drift. Drift is the minor change that is part of evolutionary pressure over time. And these are point mutations in the gene. And so every year we follow what's happening with influenza, what strains are circulating as a result of this drift. And sometimes we have more severe seasonal influenza epidemics because the drift might be a little bit more virulent than the prior drift. And what CDC and WHO do is they monitor laboratory specimens worldwide year-round to see what is circulating and what kind of drift is happening in the influenza virus. And then again, they use that information to decide what's going to go into the vaccine in the following year. So that's a natural phenomenon. In contrast to the gradual evolutionary change of drift, there's something else called shift, and that's a major change. So in drift, we have an AH1 virus that stays AH1, but looks a little different. But in shift, you have the major circulating virus was H3 and is suddenly H5. Or the major circulating virus was a human H1 and is replaced by a swine H1. So when you have a major shift like that, often due to the exchange of an entire gene segment or several, often you will have very little population immunity. Very little people have seen these new viruses before, and therefore that can cause severe morbidity and mortality. We don't have a lot of innate immunity, and that can result in a pandemic. So this is the classic slide that everybody knows or should know. So this is just how a pandemic can occur with our animal reservoirs. So let's say here's the wild bird or the wild duck, and he migrates all over the world. He mixes with a lot of other bird species at lakes and migratory pathways, and he's infected with a non-human influenza virus. And that virus can have any one of these 16 hemagglutinins on the surface and any one of these 9 neuraminidase inhibitors on the surface. And he happens to land in a poultry area or farm and meets his friend the pig. So the pig is known as a mixing reservoir because pigs can host both non-human influenza viruses and human influenza viruses. And if they are infected by both at the same time, what happens is those genetic segments can mix and reassort in that pig and possibly create a new reassortant virus that, because of its different genetic makeup, may have the capability to invade human respiratory epithelial cells and cause severe disease and a lot of morbidity and mortality. And so that's how we think a pandemic virus evolves. Likewise, in the bird, there can be direct mutations here that allow it to acquire the ability to invade and cause disease, and so it'd be straight from exposure of a human to an infected poultry or other wild bird. Okay, so we have had 4 pandemics that we know of as far as we have recorded, and of course the biggest one occurred in 1918, 1919. That was called the Spanish pandemic, and it was when H1N1, influenza A, was introduced into the population. We have a lot of myths and stories about what happened then, but the estimates are 20 million deaths worldwide, 500,000 in the US, and those are gross estimates, facilitated perhaps by World War II at the time and lots of military, World War I, sorry, and lots of military crowding in barracks and so forth. We also had other pandemics that you may or may not have been aware of because they were more mild. But in 57, 58, an H2N2 was introduced into the population and caused more morbidity and mortality than usual. This was actually due to accidental release from a laboratory, and it became the predominant circulating strain. In 68-69, from Hong Kong, an H3N2 was introduced into the population, and that actually is a precursor of the H3N2 that we have circulating today. And then, of course, in 2009, 2010, we had this swine flu pandemic. We're not supposed to use the word swine anymore because we don't want to cast any negative impressions on the swine industry. So it is called 2009 H1N1. Okay, so if you ask the swine folks, they say, well, you infected our pigs, you humans. So there's a lot of debate, and I'm not going to touch on it too much. The remarkable thing about the 1918-1919 pandemic was the mortality. And so this is just the mortality curve, which shows that due to many modern innovations, vaccines, antibiotics, better sanitation, better health care, mortality rates have gone down quite a bit, except for this big spike in 1918, 1919. And again, that was all attributed to the pandemic. And for reasons that were not quite clear, it was mostly young, previously healthy adults who were the worst off as far as case fatality, although there is a broad spectrum of disease in many different populations. And again, that might be partly due to the war happening and crowding in military barracks and encampments. So seasonal influenza is something that definitely should be respected. And I think we often take it for granted. So the numbers are here, and I work at the health department, and I do influenza. And when I hear about other people who work on mumps or measles, I go, yeah, like 3 cases I don't care about because I'm flu. And 82 million infected annually, 36,000 deaths per year, up to almost 500,000 excess hospitalizations. Higher mortality during seasons when influenza type A, H3N2 is the predominant circulating virus, and 90% of deaths will occur in persons over age 65. And here in California, we have about 3,000 to 4,000 deaths per year due to influenza, mostly in the elderly. So this just shows you who is at highest risk for hospitalization and death. And so high risk means those who have those risk factors you hear about, emphysema, diabetes, heart disease, immunosuppression. They're at high risk for more severe disease when they're infected. You see that these are rates per 100,000, and so the very young and the very old are at high risk of being hospitalized if they get influenza, and then those with those high-risk conditions. So keep in mind that those are the most vulnerable, and they're around us all the time, and we'll talk later about how we can help those who are most vulnerable for severe illness. So this was a slide done by Monto, who is like an influenza god, and this was actually done in the 60s, and he looked at a large outpatient clinic setting and identified that really the primary focus when influenza first shows up and the burden of disease is really in the school-age population. They shed a lot, there's a lot of mucus flying around, but it's actually really in the school setting where most of the acute influenza occurs. And we think what happens is, let's say, in a community when there's influenza introduced, that first it hits school-age children and is spread. And from a surveillance standpoint, we at the state, what we do is we're trying to look and see when is influenza first occurring, where is it, and who is it affecting. And often the first marker is school absenteeism. So you'll see a spike in school absenteeism, and you'll see increased visits to the pediatrician for medical care because it's usually the school children that are first infected. Then in the next cycle, what you'll see is that others in the household become infected, and so you'll have employee absenteeism because the mom and dad are sick. You might have hospitalizations, especially in the elderly or the very young, because they are more vulnerable to severe disease. And then you'll see the same phenomenon spread into the community. And this can take over 3 to 6 weeks, typically in a community, and influenza can vary into its infection rate, but anywhere between 30% to 40% of a community at one time can have influenza depending on things like the circulating virus, the strain, underlying immunity, whether they were vaccinated or not. So it can be quite an important public health problem from the standpoint of disease burden. It's fairly contagious. The incubation period is roughly 48 hours, but can be anywhere between 1 to 4 days. And adults are infectious for about a week after onset of your symptoms. However, young children can shed virus for several days. They really do love to share everything, and they can shed for weeks at a time, and if you're immunosuppressed, you can shed for months. So those are sources of transmission and infection that we just have to be aware of. This is an infection that is transmitted by large droplets, so within a 6 feet radius of an infected person, if they're coughing or sneezing, they may be spewing out large droplets that can transmit the virus to other persons. Airborne means that you have smaller particles that can suspend in the air and stay around a little bit longer. We think of tuberculosis as being airborne. And influenza is not considered an airborne transmitted virus, but there have been rare reports where it has been transmitted in hospital vents or in airplanes. So in certain situations, we know it's possible, but we consider it mostly to be a large droplet within 6 feet respiratory infection. The other thing is that there is an underestimate of how much of it is driven. Let me just say, so for respiratory etiquette, which is usually what you do when you have some kind of respiratory infection, if you have cough or runny nose, from a public health standpoint, we advise that you wear a mask. Take your tissue and throw it in the garbage. Don't use hankies where you reuse and put in your pocket and other people touch it. And definitely wash your hands. And washing your hands is probably the most important component. Influenza can live up to 48 hours on hard, non-porous surfaces. So we don't know for sure, but it's likely there's a lot of spread from doorknobs and shared keyboards and that panel that you push on the way into the bathroom and banisters, lots of different kind of just metal surfaces that can harbor a lot of different viruses, including influenza. It can survive up to 12 hours on your clothing or on your tissues, or on a tissue, like a Kleenex, up to 1 week in the body, and the lower the temperature and the lower the humidity, the more hardy the virus is, okay? So wash your hands. So the typical symptoms of influenza are demonstrated here, and almost everyone remembers the fever. So day 0 is when you likely were infected by that person on the bus next to you who coughed on you. And you will notice probably first the fever, headache, malaise, and myalgia, runny nose, throat pain, and cough. And one of the things that people say is really remarkable about flu is the sudden onset. So you're feeling fine 1 hour, and in 2 hours later you feel like just terrible. And so sudden onset is one of the hallmarks, as well as myalgia. So you're achy all over. It's not just localized to your nose and your throat, but your body feels sore, your muscles ache, you just need to lie down. And those are kind of the classic symptoms of flu. But are there really classic symptoms? Because we see a big variation in how people present when they're sick with flu, especially if you're very young. So a lot of babies and young toddlers will present with gastrointestinal symptoms. They may be febrile, but their primary complaint, or if they can't talk, their primary symptom is just throwing up or diarrhea, or just being very tired. In the elderly, it can present as mostly you're just confused, or you have a runny nose. You may not have a fever. It may be that your temperature is actually very low instead of very high. So we have a very low threshold for suspicion when we hear about influenza or an outbreak in a nursing home, because we think no one's having a fever, but that doesn't mean it's not influenza, so we often test anyway. So the classic symptoms apply to your healthy adult, but there's a big variation in symptoms that we should be aware of. Okay, so for laboratory diagnosis, this is now the gold standard. So PCR, which is a molecular test, is now the most commonly used test. Lots of folks still use this rapid test, which is the test that they perform in the doctor's office at the bedside. Tells you in 10 minutes. But that test can be very insensitive, and also not always specific. So in other words, it's not that reliable, and we advise clinicians to go mostly on your clinical suspicion and on how the patient looks to you. If they meet the classic looking signs and symptoms of flu for their age group, and this test is negative, go ahead and go on and get a PCR, because that's going to be the best test to detect whether influenza is the cause of respiratory illness. And remember, there's lots of other viruses out there that can cause the same symptoms as influenza. So there's RSV, which is a virus that affects babies. There's rhinovirus, the common cold. There's parainfluenza. There's adeno. There's lots of these other viruses with different sounding names that can be the cause of what looks like flu. So testing is very important. It's important for us from a public health standpoint, because then we understand, is this due to flu or is this due to something else? Okay, so let's talk a little bit about antivirals, and this is not as complicated a slide as it looks. There are two classes of drugs: adamantanes, amantadine and ramantadine, and neuraminidase inhibitors. And what the adamantane drugs do is they essentially prevent the virus from entering the host cell that it's trying to infect, so that it can take over the machinery and replicate and reproduce. This drug is not used that much anymore for reasons I'll get to in a minute. And this is where neuraminidase inhibitors work. So they prevent release of those progeny influenza viruses. This is the drug that we mainly use now. So the reason we don't use amantadine, ramantadine, even though they're cheap, is that resistance is now a big problem. It doesn't work very well anymore. It doesn't work in influenza B. When we used to use it in outbreaks, about 15% of patients would develop resistance in a few days, because it was only due to a single mutation where resistance would arise. And now its usefulness for flu at all is unclear, because roughly 99 to 100% of influenza viruses are resistant to these drugs. So it's unfortunate, because they were quite cheap. This is an interesting slide put out by Bright, where he looked at the surveillance systems of resistance, and it appears that resistance to the adamantanes really started in Asia and China. And it started back in 2002-03, where there was probably a lot of use, because that was right around the time of SARS and fears about H5N1. Amantadine and ramantadine are available over the counter and often used to treat the common cold. It's possible that the virus developed resistance in response to that pressure, that drug use, and then spread worldwide, although there has been other evidence that it was perhaps a spontaneous genetic mutation that led to this resistance. So no one knows for sure, but we now know that we can't use this drug anymore, because it's pretty much resistant worldwide. So that leaves us with these drugs called neuraminidase inhibitors. They prevent release of progeny virus, and they've been around for a while. The most common one is oseltamivir, or you might know it as Tamiflu. I have no disclosures, by the way. And this is a 5-day course. The other drug out there is an inhaled drug. It's more difficult to give, and we don't give it very often. There's an age limitation, so you can't use it in young children. And for someone who has a hard time with inhaler-based medicines, it can be hard to use. So for a long time, these drugs were not prescribed very much by doctors, because the data out there by the drug company was that in outpatients, so fairly healthy people with flu, if you gave it within 48 hours of onset, so that's a narrow window. Not many people get to the doctor within 48 hours of the onset of symptoms. If you did it within 48 hours, there was a reduction in symptoms by 1 day. So it didn't seem to have much benefit. It was fairly expensive, and not many physicians felt it was worthwhile to prescribe. And this drug really languished for a while without really having a niche. But then when we began to worry about a pandemic, and this probably happened around 2003-04 with SARS. When SARS emerged, if you remember, severe acute respiratory syndrome, we began to worry about what could happen with flu and if there was a similar scenario could take place. And so there began to be a lot of awareness about pandemic preparedness, and people began to look more at whether oseltamivir could have some benefit that was more than what we perceived. And so this was the first study, and many others have followed. And what it showed essentially was if you got oseltamivir, and again, the window here is 48 hours, you could decrease use of antibiotics to treat bronchitis and pneumonia by about half. And you could prevent hospitalizations by more than half. So this was the first study to say maybe if we're treating, it can prevent severe illness, and if you get to it early. And there have been many studies since. The problem is nowadays it's very expensive to do what we call a randomized controlled trial prospectively going forward. You give a control group no drug, you give another group drug. It's not considered ethical in many times, especially after it's a routine recommendation. So we have to kind of glean what we can from studies available. But this was one nice study done out of Toronto where they followed people admitted with flu that was confirmed by PCR. And they were also vaccinated, but they still got flu. We'll talk about that. And they found that there was a benefit seen even outside of 48 hours as far as death. So this study was actually a very important study as far as confirming that this drug had value, had utility, and in fact contributed to, if you recall, the effort to stockpile a lot of oseltamivir when we were worried about a pandemic coming. And Roche, the manufacturer, went from having an obsolete drug to one of the most in-demand drugs in the world, and there's been a lot of discussion about that since then. Unfortunately, we also have to worry about oseltamivir resistance. So this first showed up in the H1N1 types of flu in 2007-8, and it showed up in Northern Europe, and it was interesting because there was not a lot of oseltamivir use in Northern Europe. There's a lot in Japan, but it didn't show up at first in Japan. So it looks as if there was some type of hitchhiker gene, or a gene that conferred the ability to resist oseltamivir that was linked to another gene that was part of the natural drift of the virus. So this mutation arose. This is now something that we also worry about quite a bit. And so CDC and WHO put a lot of effort into surveillance for antiviral resistance. It's something you don't hear about a lot, but if we lose oseltamivir, we essentially have an untreatable influenza virus. So right now, there are surveillances going on world round to identify when influenza viruses come in, are they resistant to oseltamivir? This is the most common mutation, but others are popping up. So far, the profile has been, it's mostly causing only mild illness when we see it in young children or folks who've been on antivirals for a long time. So that's kind of a breeding ground for resistance. What's important to us is when we hear of a case, we contact that case and we see if any contacts have been sick, and if they're sick, if their virus is also resistant to oseltamivir, because then that would mean it's starting to spread. And so far, when folks have done that, there's no sustained transmission, there's just limited transmission. But this is something that we do worry about, that this will become something that's more predominant. And so this just shows the CDC surveillance that last year they tested almost 3,000 virus samples and found only 4 resistant viruses. So that's the good news, but we have to keep on top of that to make sure that we have some treatment available. Okay, so we're going to move to vaccine. And influenza vaccine is cheap and it's effective, but it's not used as much as it should be. So it's updated annually to protect against the anticipated strains. So again, it has 3 viruses, A, H3, A, H1, and B, okay? Because those are the ones that are circulating. Those 3 subtypes and types seem to be the ones that, once they're established, they stick. And the process is an antiquated one. It's grown in embryonic chicken eggs, and they have to be the right type of egg. Part of the whole process is ordering eggs a year before that have to be the right stage of embryonation. They have to be the right size. They have to be the right shape. The virus is injected in the egg, and then after it's grown, it's formalin inactivated. So this is an inactivated vaccine. Last season, we had about 125 million vaccine doses in the U.S. available. That's approximately 125 million eggs that were required to make that. And here's the timetable. So we're doing surveillance right now. And as I mentioned, laboratories around the world, including California and the U.S., are looking at influenza viruses, sending to CDC, sending to WHO, and figuring out what strain is circulating. So right about now, our lab is saying, any flus you have out there in California, we want to see them. Then what they do is they study and identify the predominant strains, and then by February, they have to tell the manufacturers, this is what we think will be in the next year should be in the next year's vaccine. This is what we think is going to be circulating. So this is a little bit of a guesstimate, right? Because what's happening in 8 months may or may not come true. But they try their best based on what's out there. It's inoculated into eggs, and then it gets grown over several months. Then it's blended because you have 3 hemagglutinins proteins that go into one vaccine. So you blend 3 eggs into one. And then you sterilize, package, and release. And the whole process takes from February to release in September or October. And you remember there were a couple of years where there were vaccine shortages. And that's because in this part of the process, there were some sterilization issues at one plant. There were some issues with the factory not being up to par at another plant. And so this is a somewhat tenuous process. And 5 years ago, we didn't have that many vaccine manufacturers. There is not a lot of incentive to make influenza vaccine. It's not profitable. It expires every June. Manufacturers would much rather be putting their resources into making drugs that you take forever, like antidepressants, or something for your cholesterol, or something for your blood pressure, because those are real money makers. And this is more just kind of a public health effort because they're not very profitable. It took the government to offer contracts for increasing manufacturing capacity in order for manufacturers to actually start working on making more vaccine, because there was very little incentive. So there are now 2 types of vaccine. This is the one you likely are familiar with. This is the shot in your arm. It only has the hemagglutinin as the primary protein that you're looking to get immunity against. In contrast, there's a new vaccine out there. It's been out there about 5 years, and this is the FluMist. So this is the one you inject in your nose. This is a live virus, but it's attenuated. So one of the principles of immunizations is that a live virus vaccine is going to give a better immune response than a killed vaccine, a killed inactivated. And so the concept here is this virus is attenuated and cold adapted. It's engineered so it only grows in your nose, where it's colder, than in your lungs, where it's warmer. So the idea is it grows in your nose, and you produce an immune response, and that immune response, according to the company, is more robust because you have a whole virus there. So you have immune response induced not only to hemagglutinin, but to neuraminidase and to all those other proteins in the matrix. You also have a mucosal response because you have local antibodies produced here. And in general, the theory is you have a broader immune response to this particular vaccine than to the trivalent inactivated vaccine that's a shot. This is only recommended up till age 49, and only because they have not studied it in older age groups. In practice, is it a better vaccine? It's about the same overall. When they've looked at studies, there is actually no difference in efficacy really between the 2 in adults, so you could go either way. So I want to talk a little bit about effectiveness of a vaccine because this kind of headline is actually not very good for public health. 62% does not sound very effective, and this actually was a number put out by CDC who are trying to promote influenza vaccination. So let's look a little bit at what these numbers mean, because what does effective mean? It depends on the study and what the study is looking at. Is it looking at prevention of infection with the virus? So are you looking to see if the person who was vaccinated and then got sick has the virus by PCR? Is it looking to prevent just a visit to the clinician for influenza-like illness? Is it looking to prevent severe complications like hospitalization? Or are you looking to prevent death? So lots of studies out there that have looked at different outcomes, and that's why the results vary so much. And the vaccine alone depends on many factors. Is there a match? Did they guess right back in February what's going to be circulating in November? Is the strain that's now circulating more virulent? How old is the population being immunized? Because older folks are thought to have less vigorous immune response than younger folks. Are you immunizing people who are healthy or who have underlying disease? And again, what outcome are you measuring? So this is a nice study that was done by Mike Osher. He looked at 44 years worth of data, and this is what is called a meta-analysis, where you take a lot of studies and you put them all into a big statistical package and you come out with kind of a summary estimate of what they found. You have to be fairly rigorous about how you look at the studies coming in. So he looked at 5,000 studies on influenza vaccine efficacy, and he found 31 that actually had somewhat reliable data that he could interpret. The outcome was laboratory confirmation, so it was a fairly strict outcome. And what he found in general, so let's say this is your placebo group, and this is the inactivated vaccine. He found that in adults, overall influenza vaccine, the IM shot, the intramuscular shot, was about 59% effective. This is over many years, many studies, and so you see there's a big variation here, and some were not effective at all. But so if one was your chance of getting flu from not being vaccinated, the flu vaccine decreased it by, roughly 30-40% is how you read this. And he found that in children, the flu missed because, and he looked at this because these are the studies available, not because the inactivated doesn't work. Flu mist was roughly, 83% effective. So he found that in general, there is effectiveness with influenza vaccination as far as preventing infection overall over 31 studies, okay? And that's the best I think you're going to do as far as assessing the data out there. So the message is, when there is a match, vaccination, taking into account all the studies out there and all we know, reduces disease or infection by about 70%. But it has to be remembered that even when the match is poor, even with that 70% or less, vaccination has other benefits. It reduces illness, antibiotic use, doctor visits, time lost from work, hospitalizations, and deaths. So there are other outcomes to look at that are more significant than just, I got vaccinated and now I have the flu, it didn't work, okay? Because it could be that you, by getting vaccinated, you're not shedding as much virus and you prevented your coworker from getting more severely ill, or your baby, or your grandmother, or so forth. So I want to talk a little bit about certain topics related to the vaccine, and one is doubts grow over flu vaccine in the elderly, and this has been a big topic. And so you have to remember, lack of evidence does not mean that it doesn't work, okay? It's been very hard to look at vaccination in persons 65 years and older, and part of it has been, I think he says it right here, the poor quality of available evidence. Any conclusions regarding the effects of vaccine in people over 65 can't be drawn. A lot of that is because we can't do these randomized controlled trials anymore. Vaccine has been recommended in senior citizens since the 60s. So it's now considered unethical to conduct a study where you say you don't get vaccine and you get vaccine. So you have to look at data in a different way. There's a lot of biases when you look backwards, but in the assessment of this paper, there wasn't enough data to say it did work, but that doesn't mean it doesn't work. If you look at other outcomes, I think there is some convincing evidence. So this was a beautiful paper done by the New England Journal, and they looked at 18 different HMOs, 713,000 person seasons over 10 flu seasons, including mismatch years, in multiple sites, because influenza can have different pathogenicity in different areas. The virulence can really vary. And lots of statistical attempts to control for bias. And this was in the community dwelling elderly. So people out in the community over 65. And he found that vaccination reduced the risk of hospitalization by 27% and death by 48%. So that is a remarkable result. And that is a remarkable effect of a very cheap and fairly safe, very safe intervention, the influenza vaccine. The other population that we focus on from a public health standpoint is pregnant women. So last year, roughly 47% of pregnant women were vaccinated. And this has been a really tough patient population to penetrate. Doctors themselves who take care of pregnant women do not particularly want to give vaccines or give new medications or any kind of new intervention during pregnancy because of lack of evidence and concerns about outcomes and malpractice. So it's been very difficult to target this population. There have been studies out there, and this study was done in Bangladesh because we wouldn't have been able to do it here because just of the numbers. But they vaccinated 340 healthy women in their third trimester, and they followed them after birth, and they found that there was a lower risk of laboratory-confirmed flu in the infants, and a lower risk of illness in the moms and the infants. And the conclusion was that maternal influenza vaccine is safe, there were no bad outcomes, and it can be effective in reducing risk of respiratory infection in the mom and the baby, because mom and baby are very close, and immunity in a baby can be very poor in the first few months. And I just put this up because this is significant, because worldwide child mortality, respiratory infections rank fairly high, and if you can do some intervention to prevent that in a mom, it's worth doing. And so now CDC recommends influenza vaccination in a pregnant woman of any trimester. But again, poor uptake because of suspicion and concerns about outcomes in pregnancy. So the last paper I want to go over with you is this one. In Japan, from 1962 to 1987, there was a law that all Japanese school children had to be vaccinated against influenza. And many people were interested in what would happen with influenza as a whole if you vaccinate that population that seems to be the nidus for infection in a community. And so it was really interesting. The laws were relaxed in 87 and repealed in 94 because there was a lot of parental concern about having their children vaccinated without really having any say in the matter. But it was a good look at herd immunity. And this is kind of where we're headed now. So herd immunity is when you have an immunity that occurs in a significant portion of the population, and that protection prevents transmission, because when the illness or infection hits someone who's been protected or vaccinated, it disrupts that chain of transmission. And the idea being, if you vaccinate the population most likely to spread influenza, you can prevent morbidity and mortality in the people around them. So in the Japanese study, what they did, it wasn't a study actually, it was a policy that was reviewed. So here's vaccination rates in Japan, and then it drops off when the law, when it was made voluntary. This is mandatory school children vaccination, and then voluntary, and then repealed. And this is mortality due to influenza and pneumonia in Japan in all ages. And the authors found that temporally, there is a correlation between lower mortality due to pneumonia influenza and high vaccination rates in school children. And remarkably, when they stopped vaccinating, it began to go up. This is in contrast to the US during the same time period, where vaccination has remained at a fairly low level till recently. It's gone up because of efforts to increase vaccination, but no real change in mortality. And this increase is mostly in the elderly. This is not in young children. So what the study seems to show is that if you vaccinate the right population, you can produce a herd immunity that can affect mortality and morbidity in all of us. We've seen that now with other vaccines like pneumococcal vaccination and Haemophilus influenza, where we now routinely vaccinate kids, and we've seen decreased incidences of meningitis and pneumonia due to those same pathogens in adults. So in theory, this could happen as well if we were able to vaccinate school children. So as a result, we're now moving toward trying to vaccinate everybody. We're not doing a great job. Our rates are about 40% in kids, and the best vaccination rates are in the elderly, about 60-70%. CDC wants to move to vaccinating everybody because of this idea of herd immunity, because we now have more manufacturers making vaccine, because we know that some populations don't respond very well to vaccines, so even if you targeted them, it may not be enough to protect them. And because doctors also were admittedly getting very confused about who to vaccinate. And so insurance companies would cover this, but not that. You know, you have to have this disease, not that. So finally, CDC said, well, if we just say everyone get vaccinated, it's a lot easier, and doctors won't get all confused and send the wrong messages. So everyone over 6 months is now recommended to get vaccinated, and that's to protect not only you, but everybody. So these are the current recommendations, and then just these are the official risks that make you even more incentive to get vaccinated, because you are more likely, again, from that slide earlier, to be hospitalized or die if you are infected. There are lots of vaccines available now because of this big push to have more out there. And so 90% of vaccine out there is still intramuscular, the shot. But there's some that can now be given like a skin test, so intradermal. That's not highly available yet. There's a recombinant, so it's not grown in eggs. So if you have an egg allergy, there's this option, if price is not a concern for you, because these are more expensive. And there's a high dose for senior citizens. So this contains 4 times the amount of antigen that the normal flu vaccine contains. In the elderly, because it's assumed that they have a poor immune response in general, if you give them a higher boost of antigen, they do tend to have higher antibodies in response. The problem is, for all infectious diseases, we don't know what that means. If you have higher antibody level, does that mean you're less likely to get sick or infected? No one's ever been able to make that true correlation. So the company says they now have proof that clinically, elderly people also do better. They get less ill if they get this vaccine, but we've yet to see the actual data. So right now, CDC does not recommend any preference for this until we see some actual evidence that it makes a difference in things that really matter other than just your antibody titer. But at least we're headed in the right direction as far as varieties of vaccine addressing the different issues out there. So these are the side effects. I think everyone here, I hope, has had at least one flu vaccination in their lifetime. So we all know it's painful and you might have some redness and swelling. There are really no major, very prevalent side effects from flu vaccine. There have been some issues, but in general, it's a fairly safe vaccine. These are the recommendations. Remember, WHO recommended in February what should be in this vaccine, so here they are. And so we've yet to see if this is going to be a match or not because flu season is just starting. But just so you know, there's the H1 component, the H3N2, the B, and there's a new vaccine out there called the quadrivalent vaccine. And what it has 2 Bs in it. So the Bs in general have either gone in 2 directions. It's not like the H1, H3. There's a B Yamagata lineage and a B Brisbane, or a B Victoria lineage. So you have 2 Bs, and they tend to just go one way or the other. The problem is when we've tried to guess what's in it, we've missed about half the time as far as the Bs. So if you look at this, in 2001 and 2, 77% of the influenza Bs identified in circulation were not what was in the vaccine. 03, 04, 93%. In 05, 06, 78%. So we're not great at guessing the Bs, and so the quadrivalent vaccine hopefully will address that by having both Bs in it. Again, it's in limited availability now. It's more expensive, so we have to wait and see if there's going to be an actual public health benefit in the long run when it becomes more widely available. Here are reasons given for not getting vaccinated. I'm not at risk. People around me are not at risk. This is not a serious threat to my health or health of the people around me. It can't protect me. It's not safe, and it will give me influenza. So the last one really bothers me because this is an inactivated vaccine. It did not give you influenza. And you may have gotten another respiratory infection. You may be feeling lousy because the immune response in your body is making you have a little bit of a fever, but that's a good sign. It's working. And this is actually a poll of healthcare workers who are our most difficult population to educate about being vaccinated. And so if you look at all these excuses, after what I've told you, I hope you reconsider if you've ever thought that, To me, the main problem is logistics. And I think it's very difficult for a lot of people to take off of work, or if you're a working mom with kids, to take off of work and haul your 3 kids on a bus down to a pharmacy and pay $30 a shot. I think costs and I think availability are just not enough. And I think we really need to be better about making it widely available. We're getting there. Target had a campaign to give free vaccine that was sponsored by Google and the Page Foundation. And so awareness is happening, but we have to get over this myth that this vaccine doesn't work and that this vaccine gives you flu. It drives me crazy, especially when it comes from a healthcare worker. That's not your role to not get vaccinated. So the facts, in contrast to the myths about vaccination, this is a significant killer. #1 cause of hospitalization and deaths among all diseases that are vaccine preventable. And remember, it is not the goal to prevent influenza infection. It is possible that in 30 out of 100 of you, you may get vaccinated and you might still get flu, okay? It's 70% effective. You may get a different strain than what's in the vaccine. You may not have immunity that's up to par. But the goal is not to prevent infection. The goal is to prevent severe complications from flu in either you who are vulnerable because you have a chronic disease or you're elderly, or your grandson or your aunt with heart disease, your neighbor, the person on the bus next to you. So this is really kind of a public health effort as well as an individual effort. And we need to shift our way of thinking about influenza vaccine. And public health is working on it, but I think we have to kind of demystify a lot of these myths that pop up about it's not effective and it's too expensive. I think we have to do better. Okay, I'm going to shift now to what I do in public health and talk about flu surveillance and what I do with the state and how we put flu surveillance data to work, just to give you an insight that other speakers may not have. So let's just go into what we do. Our main job is to look at what's circulating, see that it's matching the vaccine, see if anyone is getting sicker than usual, and to identify a pandemic virus that's out there. So I want to take you back to 2009, where I was overseeing flu surveillance, and it was actually, quite frankly, a really boring year. I really felt like flu was just a dead end. There's nothing happening here. In April, so the end of flu season, we were notified at the state about a patient in San Diego County, 10-year-old boy with fever, cough, and vomiting. He was previously healthy. He was not that sick. He had relatives who were sick before, and he got on an airplane while he was sick and flew to Texas. His sample had gone through a surveillance network and was identified finally at the CDC as being a swine flu. So we went back and investigated, no exposure to pigs, and sometimes there is exposures and novel viruses show up that are mild, and that happens, especially when you look more. And now we have molecular techniques that look at lots of flu viruses and identify where they're from and what subtype, and sometimes there are sporadic swine infections out there. So we thought, that's interesting, he looks fine. But 2 days later, we had another case reported from a different county. Same kind of picture, 9-year-old girl with fever and cough, had relatives with symptoms. She, again, on interviewing, had no direct exposure to pigs, but had attended a state fair where pigs were exhibited, but she never saw a pig. Her safe specimen went up through the chain, was at the state lab. They could not subtype it into the typical H1 or H3, sent it to CDC, and it was a swine flu. So when you have 2 cases in a short time frame, as a public health person, you start to worry. So especially if there's no common exposure like a pig who may have transmitted the flu to these children. So the first thing we did before getting too worried was just, okay, let's take a deep breath. These cases occurred 80 miles apart. Was there possible lab contamination? No, they were collected by different people at different times. The samples never went through the same lab. They were both positive for flu A by PCR, but you could not type them as the human H1 or H3. And they both went to CDC, were both swine flu A, H1N1, and were both genetically identical. So that was concerning. We went back and we interviewed the wazoo out of these cases. We went, for the San Diego case, he had gone to the zoo. We interrogated the zoo. We tested their boar. We really put them through a lot of trouble because we wanted to see where the exposure was. Likewise, for the state fair, we had to track down the pigs in the state fair. They had already been killed, and we could not test them. We tried to track back to where they came from, and that was difficult. So a lot of effort has gone into the zoonotic part of this, the pig exposure. But then what happened was we started to see more cases. So we had more outpatients, a father and a daughter, in April. And then the 2 pig cases 2 cases showed up from the same high school in Texas. they had not had contact with case patient A, who had flown from San Diego, but they had the same virus. And on the 16th, we had the report in California of a woman who had been hospitalized, also who had swine flu, and she had underlying complications that made her predisposed to severe flu. So again, all cases were interviewed by both Texas and California health departments. No known link in any way or any exposure between these cases. So when you look at this from a public health standpoint, there's something going on. There is person-to-person transmission happening here, and we began to worry. So while we were worrying, we contacted CDC, and CDC said, why in California are you always having these problems? So you've got these novel flus, you've got strawberries, you've got lettuce, you've got bean sprouts, everything's happening in California. Everything, chicken, whatever, you just can't get it together. And we said, we're pretty sure it's not circulating in the rest of the state because we have a very good lab. We subtype a lot of viruses. This is the first we've seen of this. And if you notice, CDC, these are on our border. So could you please investigate what's happening south of the border? So one case in San Diego, Tijuana is one of the busiest borders in the country. 500,000 people annually pass through long lines. Imperial County is, if you look at the map, it's on the other part of the border. It's a county of about 150,000 people. And, it's known for not much the Salton Sea, Death Valley. Mexicali, where this case was located, is right across the border from Mexico. And she had just been there. She was in Calexico and went to Mexicali. So there was a lot of concern that there was something going on in Mexico which does not have as great a surveillance system, and which showed up by our surveillance in San Diego and Imperial County. So as it turns out, there was on ProMed, which is now the way we hear about a lot of things, report that there were swine flu cases occurring in Oaxaca and in Veracruz in children. Those had been tested by a Canadian lab and were positive and were identical to the viruses showing up in California. So while we were all puzzling over this, the media actually got quite busy. And the headlines on that Monday were many healthy young adults in Mexico City are dying from swine flu. And I don't know if you remember these headlines, but it was pretty scary. And this is at the time where we just were learning about these 5 cases, and we were like, uh-oh, this is not good. Now, as it turns out, this high mortality was not reproduced in other locations worldwide, and we don't quite know why Mexico had such a severe outbreak. They reported 80 young healthy adults who had died from swine flu. And what may have been is that their surveillance system only picks up the most severe cases. So their surveillance looks at severe pneumonia and deaths. And so what they may have been seeing is the tip of the iceberg, a population of 10 million in Mexico City, where there are likely many, many more infected, but not as ill. We don't know for sure, but this certainly got everyone's attention and really ramped up all of our efforts in a quick way. So this was in April, and by July, an official pandemic had been declared by WHO. And a pandemic is declared not based on severity of disease, but on geographic spread. So when countries in all different latitudes and longitudes were affected and virus was identified, WHO declared a pandemic. There's been a lot of controversy after the fact about that because people have criticized WHO saying it wasn't that severe, and so you really created an economic crisis by causing alarm and so forth. But WHO was following the rules they had, and they could not change the rules in the middle of the game. So in California, we began to monitor disease, and at some point during the pandemic, we actually ran out of lab tests. We ran out of swabs to take specimens. We ran out of testing reagents, and so these numbers are a gross underestimate, right? We only tested the most severely ill. There were probably many, many more who were infected but not that ill. In the US, these are the numbers that are lab confirmed, but in actuality, it's probably around 61 million people who are really infected. That's about a quarter of the US population. 274,000 hospitalizations and 12,000 deaths. So it was likely more magnified than we're aware of based on the numbers available. So because we were where it started, and we were blamed for it, we also were the first to begin really looking at what was happening and characterizing the cases. So we had a description of our cases in the MMWR, which went nationally, and we began to look at who was infected and why, because this was important to target vaccine, which was in the process of being made, and to target antivirals, which were in limited supply. And so this is just a graph that shows you, in a typical flu season that's non-pandemic, the blue is your typical hospitalization curve. And so I've already shown you this. The very young and the very old are usually hospitalized. And if you are in an H3N2 predominant year, it's a lot more severe, a lot more hospitalizations. But what we saw in the pandemic initially was that the elderly seemed to be spared. They were not being hospitalized, and we were asking all hospitalized cases to be reported to us. And what it appeared to be is that there was some type of underlying immunity. You know, for once, the elderly like, God, thank God, I've actually got something I'm protected against rather than I'm at risk for. Because of prior exposure to previous H1N1 viruses, whether you were vaccinated or infected, and this virus has been circulating since 1919, right, 1819, there was some immunity, and that was protective. So we saw the same thing as far as mortality rates. It was quite impressive. This is 65 and under. So, you know, up until this age, 60, I think, there was quite a bit of risk of dying, and then it really dropped off when you were over 60, 65. Now, that prompted CDC to initially say, if you recall, we are going to start making vaccine, and the first priority should be those under, should be those, I think their age cutoff was 50, because seniors are protected. And that got a lot of senior citizens really upset, and I totally agree. When we looked at our cases a little more, what we found was that, yes, you were protected if you were over 60. However, if you were one of the few who were admitted to intensive care, about half died. So this was not a disease that elderly were automatically immune to. I mean, this is not, you know, black and white. If you happen to not have enough immunity and you got this influenza, you were going to do very poorly. And I think as part of this and other data coming out, CDC actually changed its recommendations by November to include all age groups, including the elderly. And so this is just an example of how surveillance data can be used to target and direct policy and limited resources at a grand level. The other thing we noticed during the pandemic was it was my job to review the deaths. And it was striking how heavy many people were who were dying. And so we've looked at that a little more. And it turns out that if you have a BMI, I think it's a body to mass index that you can figure out on a CDC website or any website. If you have a BMI over 40, and that's morbidly obese, your likelihood of dying from this influenza was 2 to 3 times more. And so this, I don't think this would have shown up if it hadn't been a pandemic, because the median age in the pandemic of infection was about 35. In contrast, in a non-pandemic year, what you're going to see mostly is the elderly, and they tend not to be obese. They tend to be the opposite. So this showed up because our population was very young who was being infected and being sick and dying. And so we were able to use the data to show that, yes, obesity is a risk factor for doing poorly with influenza and likely other respiratory infections for a variety of reasons. And then finally, we also noticed that a lot of pregnant women were not doing well. And this was shown by CDC as well, that pregnant women comprised about 1% of the population, but they were being hospitalized and dying out of proportion to their prevalence in the population. So we looked at over 100 women in California, and we found some very interesting things. Most were otherwise healthy. What we found was in reading the reports that these women would often show up in an emergency room very short of breath, and they would actually deteriorate and require intubation within 24 hours often. 1/4 intubated at admission in the ER. There were many deliveries in an ICU setting, and gynecologists and obstetricians do not like to deliver in not a delivery room. They like control, they like the appropriate equipment, not the setting where your patient is struggling to breathe and you are told you have to deliver the baby because mom isn't getting enough oxygen. There were 4 stat C-sections, 6 deaths, and 8 cases were 2 weeks postpartum. Our message from all of this was that to our clinicians, if you see a pregnant woman in your ER, you need to get her, and you think she has flu, get her to a tertiary care center, because you may have to deliver a premature baby. You may have to have a NICU there to take care of that premature baby, and you will have to take care of a woman who may be very, very ill. So community hospitals, we advise, please transport, if you can, to a tertiary care center, because these stories were quite remarkable and quite sad. And we were fighting against this kind of stuff, where Suzanne Summers said, pregnant women shouldn't get the new swine flu vaccine, and Ann Schuchat, who is the CDC respiratory head, said to Congress, maybe this year we can change that culture. It's not supposed to happen that when you're pregnant, you're fighting for your life on a respirator. So this was a big picture and a big story as far as the pandemic for us, at least. And I think it may have finally penetrated some of that obstetric gynecological care routine that vaccination can save lives and is important. The other thing we identified is if you are pregnant and have had your baby, you're still at risk. So 2 weeks out, we still saw several cases with ICU admission required and death, and these were likely infections acquired in the hospital when the mothers were delivering their babies. So a lot of infections are spread in hospitals, and the pandemic does not dispute that theory, because unfortunately they came to deliver and they acquired influenza that was severe. So I'm going to move to the last phase, which is what we're doing now to look for novel viruses. So avian influenza surveillance goes on worldwide, and this has been going on for several years. Let's start with wild birds. So many wild birds out there have influenza virus, and what mostly is targeted is dead birds. So if dead birds show up in the US or worldwide, they are tested. But it wouldn't be logistically or economically practical to test all birds all the time, because you wouldn't know if you found a virus, is this going to be transmitted to a human? It's part of their natural ecology. Also, poultry is surveyed worldwide. We're going to talk a little bit more about that, but this website kind of gives you the status of everything. Poultry in North America, humans, and humans in North America. So this was interesting to me. Highly pathogenic avian influenza, highly pathogenic means that the birds will die, is reportable, but it's only reportable if at least 75% of your flock dies. So that's a lot of poultry to die before you tell WHO or OIE about you're having a poultry outbreak. So there's probably a lot of avian influenza out there in poultry that is missed because the die-off is not big enough. And it's not as if you're rewarded if you report it, because you're likely going to have your farm shut down, a lot of measures put in place, you won't be able to sell. So there are a lot of disincentives to reporting, and that threshold, I think, to me, means we're missing a lot of avian influenza in poultry worldwide. You can look at a map of where avian influenza has been identified in poultry on the website. Now, here in the US, we have our poultry that is industrial is monitored by an organization that is actually, it's not quite independent, but they say that they monitor all chickens going to, all broiler chickens, chickens going for food for avian influenza. And if there is a big chicken die-off, there is surveillance and testing. The USDA has a brochure that they've put out for those who raise chickens in their backyard. to kind of monitor your chickens for influenza because they're not part of a regular reporting system, and so they have this brochure, and it tells you what to look for in your chickens. I don't know if anyone here has chickens. You're probably very aware of it if you do, but the chicken may have swelling of its head or eyelids or comb or wattles, which is this thing. Purple discoloration. It can have something called twisting of the head and neck or kind of imbalanced gait. They can be coughing or sneezing. They can have misshapen eggs. And then I put this picture up because I Googled depressed chicken and this came up. So they can be depressed. I don't know exactly what that means, but if you have chickens, you might know because some people get very close to their chickens. So this is if they have highly pathogenic avian influenza. There's also low pathogenic, which birds don't get that sick and you wouldn't pick that up. But we worry more about the highly pathogenic. So what do you do to protect your birds? So the brochure lays it all out. And it's actually, it's quite detailed. So you keep your distance. Actually, oh gosh, I need my glasses. So you restrict access to your property and your birds. You don't let wild birds near your birds, so that you have to separate with a barrier because the wild birds can carry the disease. You wash your hands. You wear clean clothes. You scrub your shoes with disinfectant. You clean and disinfect your equipment, including cages and tools. You don't let any vehicle come in or out without disinfecting the undercarriage. You dispose of dead birds in an appropriate manner. If you buy birds, you keep them quarantined from other birds for 30 days. You don't borrow any gardening equipment or vehicles from your neighbors who also grow chickens. You know the warning signs and you report sick birds. So there's quite a lot that goes into protecting these birds from getting avian flu because the transmission is likely if you have wild birds in the same area. So avian influenza was not really on anyone's radar until 1997, where there was an outbreak in Hong Kong. This was the seminal event as far as international avian flu. So there was an outbreak, and it was H5N1 in poultry in markets in Hong Kong. And 18 cases, 6 deaths, so it was a high mortality. This was the first time that it was documented that avian influenza viruses could be transmitted to people, and it was the first link between infections in poultry and disease in humans. And so what happened was WHO asked that Hong Kong cull its entire poultry population, 1.5 million birds, and they did that in 3 days. It was an amazing endeavor. And it did actually stop the outbreak as we know it. However, we now realize that the virus was likely still circulating quietly in poultry in China and in Hong Kong, and is what is now circulating today and is causing disease, again, in many parts of the world. So we now worry about H5N1 in Asia, Africa, Europe, and the Middle East. There have been 566 human cases reported from 15 countries. Most are children and young adults. 58% case fatality rate, so many people die if they're infected. What seems to be the case is that the highest risk factor for acquiring H5N1 is if you live in close contact with your poultry. And this is a common phenomenon in many countries in Asia and in Africa and in the Middle East. In many, many countries. So it appears that if you live with poultry, that is your highest risk, especially if you're young. It does not appear to transmit efficiently from person to person, so it still appears to be poultry to human, and that's important. So whenever they hear of cases, WHO flies in and makes sure that there is not person to person, but that it is poultry to person, because once it acquires the mutation of person to person, then we really worry because that is a pandemic. So it causes illness in birds, it's highly pathogenic, and that's how we know it's in a community. And so far, worldwide, 400 million birds have been killed in an effort to prevent spread, but it is still considered endemic in poultry in 6 countries, including Bangladesh, China, Egypt, India, Indonesia, and Vietnam. So it's still out there, it's probably widespread, but mostly affecting people who live closely with their birds. And so, this is the kind of setting where you sleep next to your birds. I don't know what this lady's doing, trimming his nails, I don't know, but they're in your backyard. And you can see by this that it's very hard to follow the recommendations that brochure said about, keeping everything clean, using bleach, using clean equipment. I mean, this is quite the risk for spread to the people who are culling these birds because they're not wearing any protection. And this is likely the scenario where we're seeing a lot of these infections. It's just very, very close contact with household poultry, because that's the culture. So there is another virus out there to worry about, H7N9, and that just showed up this spring. It is happening in China. It appears to be mainly in folks who are a little older. 126 cases were reported in April alone, with 24 deaths, so about a 20% mortality rate. Elderly with underlying medical conditions. And it's kind of funny, the profile, it's mostly male, and it makes you wonder if there's some exposure in some occupational way that we're not quite clear on. There again is no evidence of person to person. It appears to all be poultry to person. And when they've looked at patients just with general flu-like illness, they have not found a high rate of subclinical infections, so it appears that there's not a lot out there, but only a few are getting sick. If you get this virus, you get very sick. And then curiously, new cases reports dropped off in May. The current case count is 136, 45 deaths, and it may be due to the fact that China actually began to close down some of its poultry markets in response to this outbreak and under pressure from WHO. So this is just a profile of the cases of H7N9. Again, majority male, majority older. Many of them report exposure to live bird markets, chickens, ducks, not as many swine. And their contacts have all been monitored. There's been very little transmission to others that have been in contact with these cases. There has been 3 family clusters, so we identify all these to make sure that there is not sustained person-to-person transmission. It has been found in a small number of chickens and ducks and pigeons, a few and many thousands of birds that have been tested at live bird markets. It's a low pathogenicity virus, meaning the problem is the infected birds don't necessarily look sick. So you can't really say, oh, these birds are sick, we need to call and we need to test. So it's really hard to pinpoint exactly where this virus is coming from. But China did close live bird markets in the area where these cases were occurring, and that appears to have decreased spread. There are seasonal factors like warmer weather, which may have contributed to the decrease in cases because influenza likes cold. But we worry that as the weather cools off in Asia, we may see more cases. And in fact, there was a case reported last week, the first case in a while of H7N9 in a man with unclear poultry exposure in the same area. So that's another thing that we're looking out for. And again, this is a live poultry market. Again, this is very much the culture in Asia. It's very much a community gathering, and it's very hard to dissuade people from changing these habits that are a part of their lifestyle. And likewise, we have live bird markets here in California. So we have them in San Francisco. We have a network of 29 live bird markets in Southern California. And I just take this to show you, these birds are sold live. They're put in bags and carried home. There are Mexican populations that frequent live bird markets. It's very traditional culture to bring home a live bird. You've inspected it, it's healthy, and you kill it at home and then cook it. And so that's going to be a culture that's very hard to change. And so there is surveillance of these live bird markets, but it's sporadic, and it's not, I think, as rigorous as we'd like it to be. But live bird markets are not only in Asia, but also here in California, and apparently many, many in New York, which is another place of concern. Okay, so finally, don't forget the pigs, because in the last 2 years, we've also had swine flu viruses that have been circulating. There has been a variant H3N2 that we've been watching closely. We've had nearly 400 cases reported, mostly mild, although some hospitalizations. and fortunately mostly due to swine exposure at agricultural fairs. So we are not a big pig state. We don't have a lot of pigs here. But Indiana, Ohio, where they have lots of fairs in the summer, kids live very closely with these pigs. They sleep with them, they pet them, they feed them, they drink a beer around them. They're very in close contact, and this is where we've been seeing cases show up. Again, no sustained person-to-person transmission, all limited, all appears to be from pig to human and not human to human, but it's another situation that we watch very closely as well. So it's interesting because we worry about the poultry, and we also worry about the swine, but the surveillance program for swine is voluntary. And it's interesting because the swine industry is very protective of their reputation. And so the current system in place is specimens are submitted anonymously to a lab where they are tested. And there have been influenzas found, including this variant flu in pigs, but we don't know where they came from. We don't know what state. We don't know what farm, because that is confidential, protected information. We're just aware that it's there. So it makes it really tough to pinpoint what's happening where when you don't know what the source is. But that's the state of affairs right now. Okay, so I'm just going to end with a slide to try and impress you that we are a big state and we have a lot of influenza, and there's a huge machine going on right now where we are looking for people sick and processing specimens and looking at deaths and looking at outbreaks. Trying to figure out what's matching and what's not matching with the current vaccine, and that this is a very important disease. It's just mainly my goal, and that vaccination is really a powerful tool as far as preventing morbidity and mortality in the people around you and perhaps yourself if you have risk factors. I'm happy to stay after if the video goes off to answer more questions.